A very good evening for the Saturday School in Urology. We at Elkem Urocare extend our Ushna Abhyartana, warm welcome to the respected faculties, the august audience which is at the Live Center Kolkata, as well as the audiences which are present across 25 centers across the country. We are proud to host our third Saturday School in Urology, live from Kolkata, the city of joy, the city with a soul. Saturday School in Urology is fondly known as SSU, is a purely academic platform with the objective of knowledge sharing, upgradation of skills, advanced learning directly from the experts in the field of urology. After the success of our first two Saturday schools, the first which we did with on new advances in BPH with Dr. Madhusudan Agarwal, and the second one which was on the novel concepts, novel approaches on stone management with Dr. Sabnis, Dr. Mahesh Desai and Dr. Kaushik Shah. We are privileged to have respected Dr. Shivaji Basu as the moderator and chairperson for our third Saturday School in Urology, which is today on renal cell carcinoma concepts and trend. Without much ado, I request our medical advisor, Dr. Amol Ahwale, to introduce and welcome Dr. Shivaji Basu for today's Saturday School in Urology. Thank you.
Welcome all of you for the Saturday School in Urology, the renal cell carcinoma and its concept to the trend. So as we know that is the RCC is most common in the 6 to 7 decade of the life, but in India it is more earlier. So after development of the molecular concept, so regarding the VHL, so there are development of so many drugs which act on the VEGFR and the PDEGF, right? And from that, so there are trend of development of the drugs on this thing, right? So here we will answer the question so many. So which molecule is superior or non-inferior to in different trial? Now I requested invite moderator and chairperson Dr. Shivaji Basu. He is director of urology in Fortis Hospital and his area of interest in stone disease and uro-oncology. So welcome Dr. Shivaji Basu.
Good evening. Good evening to all friends, colleagues who are present here at Kolkata and our long distance friends who are joining and want to participate in the Saturday School of Urology. A warm welcome from Kolkata. At the outset, let me first thank Elkem Urocare for organizing this Saturday School of Urology, and I salute them for keeping the commitment and the continuity with such they have already performed from Agra and from Nadiad. So we will try our best to be a part of the program. We have got a galaxy of experts here. They're all very skilled and very competent and very well known in this city and this part of India. And we have got Dr. Gunjan Gupta. You will know them once they come for talk. We have got Dr. Srinivas Narayan. We have got Dr. Sharaddat Mukhopadhyay. We have got Dr. Nadeem. And we have got Dr. Pushkar Sham Chaudhary. So they are all experts in their own field. And it is a difficult task because for me as a chairperson moderator to keep the time and manage the time, because each of the subjects covered, they are the experts and they've got so much to say. But I feel like a schoolmaster in this Saturday School of Urology, just binding them to their time so that the first session, which will have the discussion on topics, 4 topics we have selected, and the second session will be the case discussion. So we will be all looking forward to the case discussion. Dr. Pushkar Shamchaudhary has got in his pocket a very nice cases for discussion, but the point of discussion, we would like to have the opinion from these experts who are experts in their own field to have their inputs on the cases. And obviously you will be electronically connected to us and can ask questions, and we will try and answer with the help of the specialists concerned. So we will not take any questions in between the presentations. Let's hear from the experts whatever they have got to say, and that will be an end of it. When there's a case discussion, everything will be covered. So I think that is the time we can ask questions. As you said, our topic today is the renal cell carcinoma, and we have got few facts. We know about it. It's just to get the ball rolling. Let me just focus on that one. We know that the kidney cancer is account for 5% of the adult male population and 3% of the female population. We also know that it's the 7th most common cancer in men and 10th in women. We know that cancer mortality rates are leveled recently for the last 2 decades, basically due to the early diagnosis and downstaging of tumors. Approximately 2 to 4% are hereditary, with several autosomal dominant disease like VHL to name with. We also know that 50% still are currently detected. There are still paraneoplastic syndromes are not infrequent, like erythrocytosis, fever of unknown origin, the Stauffer syndrome, thrombocytosis. And in early and low-risk disease, surgery is the mainstay of treatment. Partial radical nephrectomy, open lap, robotic. I don't think we have got a scope to discuss on the technicalities, which is beyond the scope of this 1.5 hours. So locally advanced disease with nodal and IVC involvement certainly needs high volume centers with special skill. That far we know, but we do not know, or we do not know so well, that the 30% of all RCCs are invasive and 20% are metastatic. And we do not know why small lesions has nodal or pulmonary mets in few cases, and why all patients bearing renal large tumors, few of them, with the help of our oncologist or without help even, will survive for 5 years. And we do not know whether the cytoreductive nephrectomy help at all in the overall survival. But these are on the process. The literatures are coming up on those, so we will have a discussion, but we cannot go to the details of each of these things. This is a thought-provoking slides, what I'm putting it through. The management of favorable tumor is pivoting around the surgical technique, but for MRCC or more invasive, it is an ever-changing challenge, and that's really the talk of the day. The prognostic scoring system for RCC, there are a lot many, and they have got a clinical relevance there. The TNM classification as it is there, it has changed from 2010. We will talk about it later. But the clinical prognostication, the one point I will touch because these are not covered in the subsequent lectures. So few lines to say about the clinical prognostication along with the pathological that gives the risk stratification. For localized lesion, the S sign is frequently used, the stage, the size, the grade, the necrosis, it was there. But for the advanced disease, the Memorial Sloan Kettering, when they started on this one, was refined in 2009 by the Database Consortium, IMDC, and the Kernosky score, anemia, time of diagnosis to treatment, corrected calcium level, thrombocytosis, leukocytosis, and altered lymphneutrophil ratio, LDH, CRP. These are the clinical prognostication. And that, along with the pathological prognostication, of which Dr. Nadeem will be speaking in details, that gives the area of counseling to the patients, or area for which the trials can be done, and area how you can talk to the patients and the relatives. But the pathological risk stratification will be discussed by Dr. Nadeem. There are molecular prognostications and biomarkers, which itself is a huge subject and needs for one-day discussion. But this is all are under process. Mind you, these are all the biomarkers, the program date, ligand 1, PDL1, and these are all on the more on the research level. Now, said all that one, the whole thing boils down to a good cancer and the bad cancer. The good cancer are the ones which are really for early diagnosed, and they can be treated well, and they can have almost a cure rate of 97%, maybe. But this all happened, all was possible because of the ultrasonologist, the imaging technique, and the interested radiologist. The ultrasounds are available in the remote corners now, and that has brought out the accidental diagnosis or in the very early phase. To talk about that one, can I call upon Dr. Gunjan Gupta, and can somebody come, please? Next slide, presenter. Yeah, where is it open? Number two. Yeah, okay, fine, I'll do that one. She'll be talking, Dr. Gunjan Gupta will be talking about the imaging in renal cancer. Dr. Gupta, thank you. Next is your first slide. Okay, this is the pointer, and this is the advance. Oh, very good. Impressed.
Hello everyone. I'm here to talk about imaging in renal cell carcinoma. I'm Dr. Gunjan Gupta from Fortis Hospitals. We've discussed all this, so I'm not going into this. But one thing, as discussed earlier, that many renal cell cancers are diagnosed incidentally, and many of them are small in size, less than 4 centimeter. Of these, many are benign lesions, and some are very aggressive lesions. So the radiologist comes into play for the correct diagnosis of the RCC, to differentiate it from benign lesions, for the correct staging of the tumor, and helping the surgeon to manage the lesion properly with preoperative planning. And obviously, the radiologist has a role in the active surveillance of small renal masses and the follow-up and surveillance of the treated patients. Ultrasound discovers these masses most commonly, where the renal cell carcinomas appear as solid tumors or complex cystic lesions with can we see the there are septa, solid nodules, and color flow on Doppler studies. Then we move on to the CT scan, which is obviously needed for these patients. On CT scan, it is imperative that we do a plane scan and a contrast enhanced scan in patients with good renal function and no contrast allergy. The scan should be thin section scans, and the contrast scan should include the corticomedullary phase, which is acquired 20 to 70 seconds after contrast administration, the nephrographic phase about 80 to 120 seconds after contrast. It is in this phase that we can see the renal masses best, and it is in this phase that we can differentiate it from the infectious lesions which commonly mimic renal masses. In infections, we can see an ill-defined lesion which has poor interface with the swollen renal parenchyma, and the adjoining fat shows disproportionate dirty signal, and there is adjoining fascial thickening. Lastly, we do the excretory phase on a CT scan, which is taken after 10 minutes. And this is done for urothelial tumors and to show the calyceal anatomy. On plain CT scan, we first look at the lesion and see its attenuation. If it is less than 20 Hounsfield unit or more than 70 Hounsfield unit, and it is homogeneous, then it is most likely a simple cyst or a hemorrhagic cyst respectively. Renal cell cancers commonly show calcification, and some lesions show macroscopic fat which is less than 20 Hounsfield unit, and this in a lesion where there is no calcification and fat is present, it is almost diagnostic of an AML. The CT features of RCC. RCCs are commonly exophytic lesions which enhance avidly, show areas of necrosis, and they contain calcification and may contain fat. These lesions enhance avidly by more than 20 Hounsfield units, but not all RCCs enhance like that. Some RCCs, like papillary cell RCC and chromophobe RCCs, enhance to a lesser degree, and they are often indeterminate on imaging, may need MRI, or may need further biopsy. Chromophobe RCC with a central stellate scar, it resembles an oncocytoma, and obviously we may need biopsy, but often biopsy is also indeterminate in these cases. Angiomyolipomas contain fat, but there are some 4 to 5% of angiomyolipomas are lipid poor, and these are also indeterminate masses which may need biopsy for diagnosis. This is a lesion which is lipid poor, and this was later proved to be AML on biopsy. We know about the cystic renal masses. I'll not go into Bosniak 1 and Bosniak 2 cysts, but we will discuss about Bosniak 4 cysts, which is mostly 90% of these are malignant, and these contain solid nodules. These contain solid nodules enhancing septa and enhancing walls. The Bosniak 3 lesions also contain enhancing septa but no nodules. And in Bosniak 2F lesions, there is no measurable enhancement in the septa. There are other Bosniak 2F lesions like totally intrarenal cysts and hyperdense cysts, which are more than 3 centimeter in size. Bosniak 2 cysts are about 10% of them are malignant, and Bosniak 3 about 50% are malignant. We use MRI as a problem-solving tool. In homogeneous lesions, which are 20 to 70 Hounsfield unit on NCCT, in indeterminate lesions I have discussed before, which show enhancement less than 20 Hounsfield on CECT, and also in heavily calcified masses where enhancement is obscured on CT. It is also used in patients where contrast CT cannot be done due to poor renal function, and also to determine the cranial extension of a tumor thrombus in the IVC in patients where CECT cannot be done. On MRI, we use a T2 weighted image. Most RCCs appear Most RCCs appear hyperintense on T2 weighted image, but it appears inhomogeneous due to presence of calcification, fat, or hemorrhage. But some RCCs, papillary RCC, and other lesions like AML are T2 hypointense and need to be differentiated on T1 gradient echo in an opposed phase image, where lesions containing fat will show a drop in signal on opposed phase images, but lesions containing blood do not show a drop in the opposed phase images. Also, pre and post contrast T1 weighted post gadolinium images are used, and this again is obtained in 3 phases as discussed earlier on CT. The diffusion weighted image is of use for determining malignancy. Biopsy is used for certain lesions, and it is being used more increasingly, especially in indeterminate renal masses, in patients with small renal masses who have opted for active surveillance, and in patients with infection, multiple renal masses, and other areas, especially in patients who opt for where ablative therapies are opted for. Biopsy can be USG, CT, or ultrasound guided. Staging of RCC, obviously, for staging, we need a good quality contrast enhanced CT of chest and abdomen, but in cases where we cannot instill contrast in a patient, a good quality abdominal MRI and a plain CT of chest is needed. Routine imaging of brain and bone scan are not needed. FDG is not needed for diagnosis and characterization of a mass. This is the staging, the stage 3A, stage 3B, and stage 3C. We are not going into details here. Here we see renal sinus invasion, and here the abdominal and the abdominal wall is invaded, so this is a T4 lesion. Here we can see nodes. These are N1 lesions, and the metastasis to the lung, bones, the ipsilateral, non-contiguous ipsilateral metastasis, and hepatic metastasis. This is obviously the M1 stage. For preoperative planning, nephrometry is used, wherein these are the parameters: the size, the exophytic or endophytic nature, nearness to the calyceal system, whether it is anterior or posterior, and location relative to the polar lines. The lesions are stratified according to the complexity, and the surgeon can choose what kind of procedure he wants to do for these patients. Vascular anatomy is demonstrated. Now we discuss about the role of PET-CT. Because FDG is excreted by the kidneys, so it is not routinely used for diagnosis of RCC, but it is a prognostic indicator for survival in advanced RCC. It is used for monitoring patients with systemic therapy by the PERSIST criteria, and also for post-operative surveillance and restaging. Other indications I am not discussing. FDG images. All PET bright lesions are not malignant. Infections, post-operative scars, and post-radiation scars are also PET bright. And newer agents like girentuximab, which is a molecular antibody recognizing carbonic anhydrase 9, it is used nowadays for doing PET-CT because it is specifically binds into RCCs. For post-nephrectomy surveillance, CT scans performed every 3 to 6 months in high-risk patients for first 2 years, and yearly scan in low-risk patients. Routine bone and brain imaging is not done unless clinically or lab indicated. For systemic therapy, more frequent scans are needed, and PET has the importance in detecting metastasis and determining the effectiveness of systemic therapy according to PERSIST criteria. Thank you for having me here. And
Thank you, Gunjan. Amazing. Covering this huge, vast subject in 12 minutes. It's something very commendable. Renal mass. Yeah. I think the small renal mass, as they say, are not always small in their behavior. So I invite Dr. Srinivas Narayan to talk on this small renal mass, its current status and handling. Dr. Narayan. Where is it? This is advanced. This is advanced. What is it?
Thank you, sir. A very good evening to everybody. Small renal mass, the topic which has been given, has generated a lot of interest over last decade or two because of its distinct behavior. What constitutes small renal mass? This constitutes a cystic or solid lesion of kidney measuring less than 4 centimeters. It refers only to the primary tumor, not to the urothelial malignancy or metastasis to the kidney. These are usually asymptomatic, detected incidentally on imaging studies. This is how the small renal mass look like, as has been described by Dr. Gunjan Gupta. If we compare the epidemiology of renal tumors with Indian data as well as with Western data, we can see the incidence, although it is very less as compared to the Western thing, but in our case, the presentation is almost 1 decade earlier. It's more skewed toward the male thing, and the most common is this thing. In our population, about 40% of the people present in stage 4 disease, whereas in Western series, almost 2/3 of the cases, they present in stage 1. As we all know, the incidence of RCC is increasing, largely attributed to increased use of cross-sectional imaging. And most of these tumors which are detected on imaging are small with a good prognosis. Patients who are diagnosed with a locally advanced or metastatic disease, no matter how much improvement has been done in treatment, continues to have poor prognosis. These are some of the risk factors. Hereditary, as we all know, apart from this, smoking, obesity with body mass index more than 30, and hypertension has got direct correlation with the prognosis. I won't be going in detail about the familial RCC, which we all know. Why it has generated so much of interest? Because historically, all small renal mass were treated surgically. In last decade or two, there have been increased school of thought to avoid intervention because they feel the most of the tumor are not malignant. Treatment will not affect the survival of the patient. Treatment comes with a cost. And there are tools like imaging and biopsy whereby we can selectively diagnose patient who requires an active intervention. Before we go for a management, we have to understand 3 parts. First is the tumor characteristic, patient's characteristic, as well as the risk of intervention. Tumor characteristic, not all small renal masses are malignant. That 20% are benign, 55 to 60% are indolent RCC with a low-grade metastatic potential, like chromophobe RCC or type 1 papillary RCC. Only 20 to 25% are aggressive RCC. And this we can know with the size, because size predicts the malignant potential. If you see the size, if it is less than 1 centimeter, the tumor being benign is around 38 to 46%, and it decreases to around 7% if the size is more than 7 centimeter. With each 1 centimeter increase in the tumor size, there is 16% increase in risk of malignancy. The natural history of small renal mass is different from the other renal tumor. Here, the median growth rate is around 2 to 3 millimeter per year. And of that, 26 to 43% of small renal mass do not grow at all. They remain static. And risk of progression to metastatic disease in small renal mass is rare, around 1%. If you compare size of renal tumor with histology, less than 1 centimeter tumor, the 46% are benign. And this decreases to around 20% if the tumor is around 4 centimeter. Same way, the metastatic potential of less than 3 centimeter tumor is around 1%. It decreases considerably when the size grows up and is around 15 to 20% if the tumor is more than or equal to 7 centimeter. Not only the risk of malignancy or metastatic potential increases, increase in size is correlated directly with the increased incidence of grade 3 and grade 4 tumor. If the tumor size is more than 7 centimeter, the G3 or G4 tumor is around 57%. Differential diagnosis, the most common diagnosis of a small renal solid mass is renal cell carcinoma in 76%. There are other possibilities. As has been pointed by Dr. Gunjan Gupta, dense fat within the renal mass is the only indicator of a benign pathology. Apart from this, there is no clinical or radiological feature that can ensure that a small renal mass is benign. These are the AUA guidelines how we deal with the small renal masses. We should have a cross-sectional imaging to characterize the tumor. We should have a metastatic evaluation including chest imaging. And every patient should be evaluated for his renal profile to assign a CKD stage based upon GFR and degree of proteinuria. Counseling, as we know, we have to discuss in detail about the tumor characteristic, treatment options, side effects. But one thing is important, which is genetic counseling. It should be done in all patients who are less than 46 years of age, who are having multifocal or bilateral renal mass, and those who are having family history. Renal mass has been discussed by Dr. Gunjan Gupta. It is not indicated in all the cases, only in cases where the mass is suspected to be hematological, metastatic, inflammatory, or infectious. It's not required at all in young and healthy patient who will choose surgical intervention regardless of an old and frail patient who will be managed conservatively regardless of the biopsy finding. Only thing that has changed that now the core biopsy is preferred over the needle aspiration. Renal mass biopsy has a sensitivity of 98%, specificity of 96%. It can tell you the RCC subtype, although there is variable information about the grade of the tumor. Missing a tumor in renal biopsy is less than 1%, that is a false negative rate. Non-diagnostic rate at around 10%, which can be substantially reduced to 83% with a repeat biopsy. It is a safe procedure with less than 1% of the people requiring intervention. And tumor seedling, which has been most talked about, is extremely rare, less than 0.01%. One of the most important factors while we decide the small renal mass treatment is chronic kidney disease, because it is more common than we anticipate, and baseline GFR is associated with long-term survival. Because in stage 3 CKD, there is 40% increased risk of cardiac event and 20% increased risk of death. So, saving in kidney function is more likely to affect survival than the treatment itself. This is just a comparison. After partial nephrectomy, the decline in the incidence of CKD stage 3 is around 3.7%, which increases to 20% in case of radical nephrectomy. And most of the people who underwent surgery, the median time to decline in function was about 5 months. So these are the options which are left to us when we deal with small renal mass. Either we do active surveillance, surgery, which type of surgery, whether it is a radical or partial nephrectomy, or we use a more conservative approach using thermal ablation. I will come in one by one. Partial nephrectomy is the standard. It should be prioritized in every patient who presents with small renal mass, unless indicated otherwise. And it should be always offered to a patient who's having multiple, bilateral, or familial tumor so as to preserve renal function. Partial nephrectomy, as compared to radical nephrectomy, has got similar outcome. It minimizes the risk of CKD progression, as well as now people think that radical nephrectomy is therapeutic overkill. And whatever the complications are there that are decreasing, which can be managed conservatively in case of partial nephrectomy. The principles of nephron sparing surgery in small renal mass is to prioritize preservation of renal function. Second, to achieve negative surgical margin, the extent of normal parenchyma that should be removed is to be determined by surgeon taking in consideration clinical situation and tumor characteristic. And tumor enucleation should be considered in cases where there is familial RCC, multifocal disease, or there is severe CKD where the patient is very near to dialysis. There are conditions where radical nephrectomy has to be done in cases of small renal mass. These are, then on biopsy we find that it is a high-grade unfavorable histology. Size is around 4 centimeter with locally invasive features like invasion of fat, venous or lymph node involvement. Or it is a very complex tumor, even in an experienced hand for partial nephrectomy. The patient should have normal contralateral kidney without CKD. Third is the thermal ablation. It is an alternative approach for patient with 3 centimeter or less size renal mass. Counseling has to be done because there is increased likelihood of tumor persistence, local recurrence, and it may require a repeat session. As compared to laparoscopy, percutaneous techniques are preferred because they are less invasive, and both radiofrequency ablation and cryoablation are having a similar side effect. But renal mass biopsy should be performed prior to ablation. Radiofrequency ablation, I won't be going in detail about it. It uses high frequency alternating current to create a temperature of 60 to 90 degrees centigrade, and tumor ablation results from protein denaturation as well as cauterization of the tumor supplying vessels. It requires the entire tumor along with the 5 to 6 millimeter of margin to be heated up to temperature of 60 degree, and the session takes around 5 to 20 minutes of time. Cryoablation said to be better than renal radiofrequency ablation. It requires rapid cooling of tissue to cause cell death. It uses double freeze-thaw cycle to cause tissue degeneration and death. Here the critical threshold for cell death is between -19 to -40 degrees centigrade. The complications are few, like post-ablation syndrome, hematuria, perinatal hematoma, temporary genitofemoral nerve injury, PUG obstruction, and urinary leak. The major complication requiring intervention is just 2 to 7%. With cryoablation, the hematuria is more common, and with radiofrequency ablation, the nerve and urothelial injury are more common. And loss of renal function after these two procedures is only 0.5%. If you compare cryoablation with radiofrequency ablation, cryoablation allows treatment of central lesion near ureter and collector cyst because there is less risk of ureteral stricture than with radiofrequency ablation. Cryoablation is less painful, and we can actually determine the treatment adequacy in cryoablation. Cryoablation is associated with the increases of hemorrhagic complication because blood vessels are not cauterized as with radiofrequency ablation. With a tumor, small renal mass less than 3 centimeter, the primary success rate is around 95 to 98%. The local recurrence is only 4 to 7%, and repeat ablation in case of failure results in 100% secondary treatment success. Metastasis-free 5-year survival is around 95%. When we compare with partial nephrectomy with thermal ablation, we can see the 5-year cancer survival is comparable. Only thing is that local recurrence is bit higher and complications are bit higher in the partial nephrectomy group as compared to the thermal ablation group. Coming to the active surveillance, this is basically the ultimate nephron sparing treatment. It should be offered to all patients where the small renal mass is less than 2 centimeter, even to the healthy person. And it should be offered to all patients who are having small renal mass where the risk of intervention or competing risks of death outweigh the potential oncological benefit of treatment. What is the basis of this active surveillance? The basis on various meta-analysis, it has been found that most small renal mass grew relatively very small, slowly with a median of 0.28 centimeter per year. And they pose very low risk of metastasis, that is just 1 to 2%. And we are having those lesions, small renal lesions, which progress to metastatic disease, demonstrate rapid radiological growth, which can be determined on serial imaging. What is the protocol for this active surveillance? Staging chest X-ray and abdominal imaging is done every 3 monthly in first year, twice in second and third year, and yearly thereafter. This active surveillance protocol should be stopped if the tumor grows more than 5 millimeter per year or reaches 4 centimeter size, where the chances of malignancy is higher, and patient should be offered treatment, active treatment, depending on clinical characteristic. These are the factors, patient factors like elderly with less than 5 years of survival, high comorbidity, poor functional status, and marginal renal function. Their active surveillance should be preferred, and rest all the patient intervention should be done. If you leave like that, if you are not treating a small renal vas, what can happen? The median growth rate is just, as I told you, 0.2 to 3 millimeter per year. In 30% of cases, over a period of 25-month follow-up, there was no growth. The metastatic potential is only 1.3%. And if you compare with the surgery, at 1, 2, and 5 years, survival advantage of surgery over active surveillance was 5 to 9% only. This is a meta-analysis of all radical nephrectomy, laparoscopic radical nephrectomy, partial nephrectomy, laparoscopic partial nephrectomy, radiofrequency ablation, and the results are comparable. Even the metastasis-free survival is ranges from 89, and it is more in patient with the cryoablation and radiofrequency ablation. The cancer-specific survival, as we can see, is almost comparable. Here, there is another data from the Western group. The results are comparable, even the metastatic recurrence-free survival, which is why we are doing intervention, is similar. And you can see, even in active surveillance, there is 97.7% metastasis recurrence-free survival. This is just an outline before I summarize. In a healthy patient with clinical T1, everyone should be offered partial nephrectomy if feasible. If not feasible, radical nephrectomy, and then there are the other options. But those patients who are having major comorbidity with increased surgical risk, the recommendation is either we should go for an active surveillance or thermal ablation, and in case patient takes a risk for a partial nephrectomy, that should be offered. Thank you.
Thank you, Dr. Narayan. Thank you for a very comprehensive talk on that one. Next. We discussed about this in the first lecture we have done, is on the clinical prognostication and the risk stratification. No, other one, 4. Now we will see what Dr. Nadeem has to say about the pathological prognostication and how do you risk stratify renal cell cancer. Dr. Nadeem. That's the progression, that's the point.
Thank you, Shivajida, and I would at the outset thank Team Fortis, Shivajida personally, and Team Alkem for inviting me here. I am celebrating 25 years working with Shivajida. Thank you so much. So we start here with pathological parameters assessed on biopsies and resection specimens have a pivotal role in the diagnosis, prognosis, and management of patient with renal cell carcinoma. Prognostic assessment of cancer is a core activity of practicing diagnostic pathologist. With this opening preamble, let me come to the main topic, which is pathological prognostication. And I think you have seen monochromatic and bichromatic images. It's time to see some multichromatic images. So if you look at the prognostic criteria which we see, they can be classified into these 4 groups: anatomical, histological, clinical, and molecular. And I think by the time we come back to Calcutta, you'll be talking more of molecular because that is the thing in vogue. So I'll be talking about anatomical and histological basic prognostic markers, which we deal as pathologists. Coming to anatomical criteria, as you can see, anatomical primarily is covered by P staging or the pathological staging of the TNM criteria. Here, what is most important is the size of the tumor, which sets in the stage 1 and 2 of the disease. But what is very important, and I would like my surgical friends to understand, is as essential it is for us to measure the tumor, is so important for you to send the tumor intact. There's no point cutting it and sending it in pieces, otherwise this entire aspect gets down the line. Furthermore, many a times we are asked questions. Dr. Nadeem, you have set the tumor size as 6.9. Did you consider shrinkage or formalin fixation artifact? Would I consider this to be 7.3? For this, the answer is very simple. The entire prognostication protocol which was set up by the TNM criteria was a retrospective study, and all the tissues which were studied were already fixed. So 6.9 is 6.9 and not 7.3 by any standards of fixation or shrinkage. And this becomes very important in our criteria of setting up things up. And as you can see, capsular invasion is equally important. So for us as pathologists, we start by marking the tumor from outside and then opening it up to exactly identify where the capsule is finishing and where the tumor is penetrating. It is very important for us to understand this particular diagram, whereupon, if you look at it, involvement of adrenal is considered to be a T4 disease. But contiguous involvement of adrenal is a T4 disease, but a non-contiguous involvement of adrenal is an M1 disease. And it is very essential for the pathologist to exactly locate the adrenal before setting into cutting the specimen through. And we would expect that specimen to come like this, and that is very important. Now we come to the alterations in the TNM protocol. TNM has been having various additions every 2 to 3 years. And in 2017, they came up with the TNM 8. And there were some alterations in the TNM 8, which is very essential to understand. It is very important for the pathologist not only to tell you what is the tumor and whether the capsule is invaded, but it is very important to tell you how the invasion has taken place. Whether it is in, whether the invasion is infiltrative or is it pushing. As you can notice, the entire 3-year survival of invasive infiltrating tumor invasion of the capsule changes remarkably from 75% to 27%. So it is very important for the pathologist to tell the surgeon and the oncotherapist that the invasion is infiltrative or having a pushing margin. Furthermore, we also know that vascular invasion of various tumors sets the tumor into a high prognostic criteria. But in renal cell carcinomas, sinus vascular invasion is only 3A disease and not further down the line. The new changes in the TNM 8 with regard renal vein and inferior vena cava invasion is that earlier gross invasion of the renal vein as well as gross invasion of the vena cava was considered a part of the TNM staging. But in the new modified TNM revision 8, even the microscopic invasion of the renal vein is considered to be very important. Now we come to the next part, the histological prognostication criteria. And if you see the histological prognostication criteria, we have the RCC subtype, the tumor grade, the sarcomatoid feature, vascular invasion, tumor necrosis, and invasion into the pelvis. We go one by one, the subtype, which is the next part of any report. If you look at the predominant tumor cell type, you would find that 95% of the renal tumors come into these 3 categories. That is either clear cell, papillary, or chromophobe. And the prognostic, if you see the clear cell has the worst prognosis compared to the papillary, and chromophobe is better than the papillary. And within the papillary, the type 1 is better than the type 2. And this is one feature morphologically of a clear cell papillary carcinoma. What is very important for everybody to understand in renal tumors is the more cystic is the tumor, the better it is going to behave. Unlike other tumors where cystic lesions are considered to be of bad nature, particularly in GI, but in renal tumors, cystic lesions are of a better prognosis. So in a report, one should always try to see whether the GRAS description is talking about percentage of cystic lesion present in the total tumor. That is very essential. This is the papillary, and here you can see this type 1, so the cells are all monomorphic. Then we have the type 2, where the cells are more pleomorphic. And it is very essential, it is not important only to talk about papillary renal cell CA, but it is important to say whether it is type 1 and type 2, because the prognosis changes remarkably between 1 and 2, 1 being of a better prognosis compared to 2. Now this is the chromophobe tumor, and this is the tumor which creates the maximum confusion. The reason behind that is this behaves better, but if you are not able to understand the histology well, you may consider this to be a granular renal cell carcinoma, which is of a very bad prognosis, even worse than the clear cell renal cell carcinoma. Now, if you generalize, then you will see that in general, clear cell renal cell carcinoma has a worse prognosis compared to papillary, compared to chromophobe, even if you stratify them for stage and grade. Now, these are some of the other tumors which are rare, and they comprise only 10 to 15%. And here, as you can see in the upper part, that all the low malignant tumors are cystic. Whether they are acquired or genetically, they are all tubulocystic, while the aggressive tumors are either solid or necrotic. Now, what you saw earlier was the book picture, which we generally don't see. We see a variation of tumors on histology, and they can be clear, they can be granular, they can be oncocytic with papillary, and they can be granular as well as clear. It is very essential for the histopathologist to tell you what percentage of the tumor is clear and what percent of it is granular. If the granular component is more, the tumor is likely to behave more aggressively. And you can also see that many a times you see papillary clear cell tumors, you see chromophobe tumors very much stimulating the oncocytomas, and there is the time when the histopathologist has to take help of immunohistochemistry. And immunohistochemistry will help you in trying to exactly delineate which type of tumor it is, and then you can further go on to classify on the unusual tumors by the help of immunohistochemistry. Now we come to the next part, which is the tumor grade. The second most single parameter after TNM staging is the grade of the tumor. We all went through almost two decades following the Fuhrman's tumor grade protocol. And if you see the tumor grade protocol by Fuhrman's, you see that there are three criteria, two for the nuclei and one for the nucleoli: size, shape, and the presence of nucleoli. And if you can see, grade 1 is like a small lymphocyte, and grade 2 is like an activated lymphocyte. The problem is that for me, it can be grade 1, and for the next pathologist, it can be grade 2. And there were a lot of inter-observer variations, which led to many people trying to shorten the 4 grades into 3 tier, and then into 2 tiers. But then this inter-observer variation of this important parameter led to us losing the Fuhrman grade to the WHO or the new ISUP grade. What the ISUP and the WHO grade has done is they have removed the nuclear size, the chromatin, and they have only held on to the nucleoli. And so it is very easy for us to pick up the nucleoli, hence the inter-observer variation is much less, and this holds on to the grade protocol. So now you see, the clear cell and the papillary carcinomas, they are the ones in which this grading applies. It does not apply to any other tumor process. Next, we come to the sarcomatoid feature. We have this concept that sarcomatoid renal cell carcinoma is a type of renal cell carcinoma. It is not. It is basically an endpoint of all renal tumors, whether it is papillary, chromophobe, clear cell. When the tumor dedifferentiates, it becomes sarcomatoid. And the presence of focal or diffuse sarcomatoid area categorically makes it a grade 4 tumor. So this is very important. The next feature is the microvascular invasion. Although the microvascular invasion is considered 3A in the renal pelvis and the perirenal fat, but independently, this is a poor prognostic feature and should be mentioned in all reports. Next, we come to tumor necrosis, and it is very important. Why it is important? Because two things, the type of necrosis and the type of tumor having necrosis. We need to find out whether the necrosis is coagulative or ischemic. If it is ischemic, it is because of tumor embolization and should be disregarded. But if it is coagulative, it is of extreme significance. The next point of necrosis is that papillary renal cell carcinoma per se will present with necrosis. So presence of necrosis in a report of papillary renal cell carcinoma is not important. But presence of necrosis in a report of clear cell or a chromophore renal cell carcinoma gives it a bad prognostic indicator. Furthermore, for my oncotherapist friends, if you have necrosis, treatment efficacy is definitely going to go down because of poor penetration. Now we come to a standard report. This is what we reported just day before yesterday. And as you can see, the report can be put, it need not be very descriptive. What is important is if you are covering all the prognostic parameters and giving a proper grade to the tumor, and that is good enough for the surgeons, that is good enough for the therapists, and it is good enough for the patient. Now we come to various prognostic models. I'm not going to go into details of this. Various nomograms have been put up. This is the European Association of Urology one, and I think my other friends are going to handle this better. Just last slide, this was, Shivaji asked me to just speak few words on this, core biopsies versus FNACs, and I think Dr. Srinivas has also spoken about that. It's time that core biopsy is taking over for two reasons. Number one, the biopsy needles have improved significantly, hemostatic protocols have improved, imaging protocols have improved, and more so, he showed us 80 to 90 to 100, almost 95% accuracy. That accuracy is not purely on morphology. That accuracy is purely on immunohistochemistry and molecular. And because of the availability of immunohistochemistry and molecular techniques which can be applied to small biopsies, accuracy of core biopsy has improved significantly. But then there is only one problem here. The problem is tumor heterogeneity. All renal tumors are grossly heterogeneous. So if you are trying to only base your report on morphology, you will be more wrong than right. But if your report is based on morphology, immunohistochemistry, and molecular, then you are more right than wrong. Thank you so much.
Thank you, Dr. Nadeem. That was a fascinating talk, starting from the evolution to the current status. I think that got the picture quite right. Now, now we started, Dr. Narayan talked about the small renal mass. There's one spectrum, and the other spectrum is the advanced and the metastatic renal cell carcinoma, or MRCC. To talk on that one, we have gotten very, very competent and very well-known oncologist, clinical oncologist, Dr. Sharad Dutt Mukhopadhyay. Can I invite him to talk on that one, Sharad Dutt? Thank you. This is the slide with advancement. This is a pointer.
So thank you very much, Dr. Shivaji Basu. I had the rare, I hope that I am privileged enough to be a student of Dr. Shivaji Basu. When he returned from England, I happened to be a student in medical college, and sir was there as a pool officer. So thank you very much, sir, for those kind words of appreciation. So my job is a fish out of water. It's a surgeon's audience, and I'm a person who doesn't deal with a knife. So milestones in the management of metastatic renal cell carcinoma. Dr. Gopal Krishnan asked me to talk about beyond first line. The surgeons are now well aware of the first line treatment. So what we do when it goes beyond the Pazo and the Votrient and the sunitinib, renal cell carcinoma had always been a surgeon's game. Only the knife talks. The pellet and the drug and the capsules doesn't. I accept it. But there are a good many advanced renal cell carcinomas. 20% of the patients present with metastatic disease by US standards, by US data. And those who are being operated with a curative intent, out of them, 30% at the end of the day will become metastatic. So what we have a cup of tea where it's always half empty. I am a pessimist because I deal with cases who are metastatic. So never forget, the knife really talks, but the talking ends at some times, and half the cases in the United States are metastatic. God bless India. So systemic therapy for advanced renal cell carcinoma, don't get afraid. I'm not here to teach you the chronology of the drug. I'm not here to teach you the history of pharmaceutical industry. I'm only to say from this cartoon that now we are blessed with the luxury of being indulgent with so many choices. Again, I'm not here to teach you the chronology, but a simple bit of arithmetic. From 1992 to 2005, 13 long years, we had only 2 drugs, interleukin, high dose, and interferon. Next, in the next 13 years, from 2005 to 2018, we had 13 more drugs. Thank you very much, not to the doctors, because of these 13 new drugs, 5 guys have won the Nobel Prize. So it's basic research which is talking, not the knife. The choice of targeted agents is the first line. Everyone knows the name. I'm going to talk about 4 drugs, not talk, but tell you about 4 drugs, 4 great trials. If I talk about these 4 drugs, you look at the data, the median survival for temsirolimus is only about 5.5 months. Yes, I'm going to talk about months because people doesn't get to live long with a metastatic disease. Out of the rest, the 3 have got a survival advantage of about 10 to 11 months. So let's concentrate here. Out of these 3 drugs, there are 2 drugs which are oral. And everyone are happy to have an oral drug. So the choice is obvious. It's sunitinib and pazopanib as the first line TKI. It's simple. Pazopanib is better. Why? Because of ease of use, more quality of life, lesser adverse events. We didn't wait. The 5 guys who got Nobel Prize, out of them, one is again working on another thing which is called the laboratory potency of the VEGF TKIs. We all know about 3 drugs, sunitinib, pazopanib, and sorafenib. If we look at the data now, this is a lab data. The potency of these 3 drugs are much, much less when we compare them to axitinib and tivozanib. So let's put that to clinical usage. Axitinib, not a fancy drug. It's the same old wine in a new bottle. It's a VEGF TKI, nothing new in it. Now it's approved as a first-line treatment in combination with pembrolizumab or avelumab, and also used as a second-line treatment. And this is a trial. Axitinib was compared with sorafenib as a first-line drug, and what we got? We got an advantage when it was compared with sorafenib as first-line metastatic renal cell carcinoma in treatment-naive patients. We got an advantage of 10 months against a 6.5 of sorafenib, and we got an express approval from the FDA. Cabozantinib, again, not a fancy drug. Another old wine in another new bottle. But it has got something advantage, say as champagne. It's bubbly. It's not only VEGF TKI, it is also an anti-RET and an anti-MET. So 2 advantages. One hand, we have got the VEGF TKI, and another, we have got the anti-RET and anti-MET parts in it. Indicated as first line treatment naive metastatic renal cell carcinoma, FDA approved. The trial, Cabozan. Cabozantinib versus sunitinib. The data, simple. Sunitinib, first line treatment naive patients, metastatic renal cell carcinoma, median progression-free survival 5.6 versus cabozantinib 8.2. Approved, FDA. First line treatments, done. Let's conclude. Sunitinib, pazopanib, bevacizumab, tivozanib, and cabozantinib. Oh, difficult and tongue twisters, but we'll have to learn all these names. They are all approved and they are improved the PFS. Pazopanib is off choice, the best kid of the block. Shows similar efficacy, good quality of life, less and less adverse events, and less non-compliance. Tivozanib, the most controversial of the drug, approved by America, approved by Europe, and not approved by America. Controversies galore. And I have heard of anecdotes where in the board meeting, the directors walked away in FDA. So they are not going to approve tivozanib in the United States, but it's approved as first line in entire Europe. Axitinib is active. Phase 3 trial did not meet primary endpoints. Perhaps you overlooked the p-value was not a good lot of zeros, so it was not that strong a trial. Cabozantinib is active, but got express approval only on phase 2 data. Whatever we do and whatever you use, ultimately these patients are going to progress even after pazopanib and sunitinib. So we need to have a good second line of defense. Everolimus. We were talking about VEGF, TKI, 1, 2, 3, MET and RET. These are all pathways. There is another pathway which works, which is called mTOR. What is basically mTOR? Not very difficult. It's not Hebrew. It's medical science. mTOR is a mammalian target of rapamycin. So what does it do? What's hunky-dory about mTOR? The tumor cells go on growing and multiplying. So in the tumor microenvironment, there is hypoxia. The tumor cells want air, oxygen, blood, nutrition, food. Who is going to give them? mTOR is a protein which induces HIF, H-I-F, called hypoxia-inducible factor. So what did this HIF do? This HIF promotes VEGF, creates angiogenesis, and the oxygen returns to the tumor cells and they start to multiply. Simple. So what we do, the Nobel laureate thought about this, he got a Nobel Prize and found out a drug called everolimus and temsirolimus, which are mTOR inhibitors. So in second line, it was tested in a phase 3 trial against a placebo and got a gentle and modest advantage of 4.9 months versus placebo's 1.87. So advantage of 3 months only. But still, it's advantageous. The freshest kid of the block, the talk of the town, the Nobel Prize winner of 2017, the checkpoint inhibitors, the immunotherapy, the fifth pillar of oncology. That's called nivolumab. It's immune checkpoint inhibitor. So what's so fancy about this? There's nothing fancy about this. This is using our own dirt within the body against the dirt of cancer. So it's a monoclonal antibody, programmed cell death 1 protein called PD-1, which blocks the interaction of PD-1 with PD-L1. What's PD-1 and PD-L1? So these PD-1 and PD-L1 are usually expressed on activated T cells in normal human beings. And why they are activated, why they go on to bind to each other, because had there been no PD-1, PD-L1 interaction or a marriage, then we would have died, we wouldn't have existed. A simple viral fever would have created autoimmunity, and we guys wouldn't have been here to present a lecture. So this is the interaction between two good ligands which creates immune homeostasis within the body. But the tumor cells are very intelligent. They have borrowed this idea and they've utilized this idea for their own survival, called immune escape. They escape the onslaught of T lymphocytes by this. The two Nobel laureates, three Nobel laureates, two American guys and one Japanese, found out a way. They created a monoclonal antibody which blocks this interaction, and the tumor are now being killed by the body's own activated T lymphocytes. Simple. So it's indicated in advanced renal cell carcinoma in two ways, and second line and in combination with ipilimumab as first line. The trial. So nivolumab was compared with everolimus in a heavily pre-treated second line metastatic setting, and we had an advantage of 25 months with this immune checkpoint inhibitor against a 19.6 months. One can say, so the Nobel laureates didn't do a good job, only a 6 months advantage. Let's wait and see. Another drug called lenvatinib is nothing great. This drug is a good old VEGF TKI. It has been approved in advanced renal cell carcinoma second line along with everolimus. This is a trial, three-pronged trial. Axitinib and cabozantinib I've talked as a drug of first line. They are even worthwhile in second line setting as well. So second line options. When the patient progresses on sunitinib and pazopanib are good old drugs, we have got a number of options right now. An mTOR inhibitor called everolimus and temsirolimus, the new drug called axitinib, the checkpoint inhibitor called nivolumab, the cabozantinib, and obviously the lenvatinib and everolimus combination, and avelumab. So new agents, selective combos. We have got a bread, we have a butter. When we have both, we put in some vegetables and chicken and create a combination even more tastier. So when we have a drug which has got a unique mechanism of action and a second drug with a different but unique mechanism of action, we hope that if we can combine these two guys, then we are going to get a wonderful result. Correct. So I'm going to describe now three combos, all being tested against the age-old sunitinib. And let's look at the data. The first combo, a new drug, ipilimumab. It's similar to nivolumab. It's again a checkpoint inhibitor, but it blocks a different molecule. Paucity of time, don't go into details, but it's similar checkpoint inhibitor. So it's combined with another checkpoint inhibitor, which blocks a different ligand. We have got the first combination called niv-ip combination. Nivolumab, ipilimumab combination, compared against sunitinib, the grand old giant of metastatic renal cell carcinoma. The result, astonishing. 26 months for sunitinib, for the combination nivolumab and ipilimumab, not yet reached. It's 4 years. Wonderful results we are getting. Next combo, pembrolizumab. It's a very similar drug like the nivolumab, again a checkpoint inhibitor. So what happens if we combine in with the age-old axitinib? So the next combo is called PEMAX combo, pembrolizumab with axitinib. So let's look at the result. Tested against sunitinib, the trial is called Keynote 426 trial. Let's look at this rubric only. The median progression-free survival, PEM plus AX, 15.1 months, sunitinib, 11 months. That's not the end. At the end of 12 months, this is only a 3 month, the trials are all on. We have got a 90% survival rate with this combination against about 80% with sunitinib. The trial's still on. Avelumab. This again a monoclonal antibody, which is again a checkpoint inhibitor. And when it's combined with axitinib, we get this called AVAX, axitinib avelumab combination. Trial called Javelin Renal 101 trial. Let's look again as a rubric. The median progression to survival, 13.8 months with this combination AVAX, 8.4 months with the rest. This is the most important. I thought Dr. Nadeem would have spoken something about it. The PD-L1 positive tumors is 55.2% response rate, but only 25% with sunitinib. I hope that you would touch upon this subject of PD-L1. This is the second slide. If you have got eyes, please spot. It is 2020 recommendation. We have to be not up to date, but before the date. So what's happening here? Very simple. The first line giants, pazopanib, sunitinib, still clinching on, but the pole position is lost. The pole position taken by axitinib and pembrolizumab. In the poor performance, there is no more pazopanib and no more axitinib. New drugs being recommended in the guidelines. The combination of ipilimumab, nivolumab, axitinib, pembrolizumab, and cabozantinib. The subsequent therapy, second line, nothing called pazopanib, sunitinib, bevacizumab, all replaced. In 2020 February, these are the guidelines coming up with preferred regimens in second line, cabozantinib, nivolumab, ipilimumab. But what shall we do in Calcutta? We don't have these drugs. So my choice, this is my choice. This is called bread and butter bedside. Start off with the sunitinib or a pazopanib. If it progresses, consider nivolumab, axitinib, cabozantinib, lenvatinib, everolimus. So far, you see that the patient can afford. These are costly giants. If it progresses, everolimus. Conclusion. Standard of care for advanced renal cell carcinoma has dramatically changed in the era of targeted therapy and immune checkpoint inhibitors. Standard first-line therapy for most patients is a VEGF TKI till now, but it's being replaced by nivolumab and ipilimumab combination. Nivolumab-ipilimumab combination has got express approval by FDA in 2018, April, for the treatment of intermediate poorest patients. Standard second-line therapy and beyond for most patients are combos of NIV or IP or nivolumab as single agent and cabozantinib. Additional combination therapies like lapatinib, the great old drug from breast cancer, tamoxifen, these are being studied. Metastatic renal cell carcinoma doesn't carry a good story. This presentation is just in the memory of many and many patients who have let their lives down. To all the patients who have succumbed to renal cell carcinoma. She might be a marvelous mother, a caring colleague, a sincere sister, a wonderful wife, a friend who felt, a great human being. Thank you very much.
What a talk. I wish I could have heard it for another hour or so. But we have to move on. We have got a very interesting cases now. Dr. Pushkar Shamchaudhary will be presenting. But the cases, I mean, it depends on how far and what sort of time we can carry on. But we will proceed with the cases. And the questions will be asked electronically, and we will ask the panel to answer the questions or give an input to that one. So it's coming from the other centers as well. Are you ready? So Pushkar Shamchaudhary is a consultant and urologist at Fortis Hospital. Can we get the camera on the middle so that they see all the panelists in the middle sometime? Carry on. Okay, fine. Yeah, thank you. That's fine. Thank you, Pushkar. Can we request our panelists, Dr. Srinivas Narayan, Dr. Nadeem, Dr. Gunjan Gupta, and Sharad Dutt, to come on the stage? So if there are questions, depending on the cases, and you can have your input there. Thank you.
Thank you, sir, for this opportunity. Now we all have been wiser with the inputs from our panelists. So now let us put them in our use in some practical situations that we face in our day-to-day practice. So our first case, it's a 60-year-old professional musician with hypertension as only comorbidity was detected to have polycythemia. And an ultrasound revealed a space-occupying lesion in midpole of the right kidney. The renal function of the left side was normal with a GFR of 69 ml per minute. Creatine was 1.01. All other parameters were normal. And he wants to live a cancer-free life. So this is the ultrasound figure which showed a 5 centimeter, around 4 centimeter midpolar mass. These are CT scan images. You all can see? Yeah. So these are the CT scan images. So the question is to the radiologist that how do we decide about whether this case is amenable for or the nephrometric score to plan whether it's a high risk, low risk, or how to go about with the management.
Hello. The nephrometry score needs to be done, wherein the R is the size, since it is 4 centimeter, so that means it will be graded as 1 on the R score. It is about 50% is endo and exophytic, so I'll label it as 2. It is indenting the renal sinus, and I need to measure the distance from the calyx, but since it is indenting, I think it should be more than 7 millimeter. Yes, it is abutting the vascular structures, so it is less than 7 millimeter, so here the score will be 3. It is anterior, and on the polar, may I see the coronal section? It is in the midpole, so it is 3. So 3 plus 3 plus 2 is 8, and 1, 9. So it will be an intermediate risk tumor. That is it.
Thank you. Now to our panelist surgeons, considering that it's an intermediate risk, how to take a decision in this person whether to go ahead with a partial or a radical nephrectomy? Sir.
Hello. First of all, the tumor is almost indenting the calyx, and as Dr. Gunjan says, it's intermittent, but there is a large cyst on the lower pole. Now, this is the tumor. I mean, if it is above 7 centimeter, then one would go for a radical nephrectomy, surely. But this one, with a characteristic position, and in absence of an ultrasound operatively, I'm a bit scared about doing a partial nephrectomy. So I will go for a radical nephrectomy here, laparoscopic.
Dr. Naran, any other imaging would you like to have to help you plan if you are planning to go for a partial?
Hello. We need to know what is the renal function, what is the status of the other kidney. And second, if you plan for a partial nephrectomy, we need to have this CT angio.
So we need a renal angio if we are planning. Since the nephrometric score makes it an intermediate risk, and the GFR of the other side was...
I just simply need to add a simple point that have we done a metastatic screen?
That was my next question, that any other
That's
imaging
the most
should we do?
important thing before you venture with a knife. We have no CT scan of the thorax. Even small tumors present with brain mets. That's most important thing.
So
That's the first question.
Do you recommend doing a CT thorax in all cases of RCC?
The standard checklist as per guidelines is very simple. It requires a metastatic screen irrespective of the size of the tumor. It's better always to do a metastatic screen. I'll tell you why too. The guidelines are there. It's not sacrosanct. It's not the Quran. It's not the Bible. It's just to lean back upon. The second is the present day's medical legal status. Don't forget, Khudana Khasta, if there is one small creepy tumor in the brain, might be a second primary, but we need to know before that. When we venture with a knife and tell the guys that, okay, we are going to do a curative surgery, my money is always with a CT scan of the thorax at least. I think Gunjan will be the better person to say.
I think a CT scan of the thorax needs to be done.
In all cases of RCC?
Should be done.
I think this is a debatable point. It's a simple tumors with the chest X-ray is enough. But if there are suspicions in the chest X-ray or there's a larger tumor, high grade, then HRCT is certainly concluded. So I don't think it's a small renal mass. We will just do a HRCT all the time. But this one, there is nothing wrong in it doing HRCT, but that puts another cost to that.
Because we have to consider the numbers needed to treat. So in that case,
Another thing I would like to add is, since we are doing a CT, we get the images of the basal lung fields on the CT because the diaphragm is shaped like a dome. So it is the job of the radiologist to look at the lung images also. If they are visible in there, we need to tell
so that is what we practically find, that most of the time it's the radiologist who inadvertently we don't ask for a CT thorax, we do a chest X-ray and proceed. But when they do the CT scan, they take the lower cuts and they mention if there is something suspicious, and then we go ahead with a CT. Otherwise, in high-risk patients, we generally go ahead with a CT scan or do the metastatic workup. So in that case, we don't have a renal angio because we had decided for a radical nephrectomy and the patient underwent a radical nephrectomy. So our next case, it's a 74-year-old male having diabetes, hypertension, CKD with a baseline creatinine of 2.4. He had a history of urosepsis and pyonephrosis with renal abscess 3 years back, and USG revealed a 3 centimeter endophytic anteriorly placed SOL in the mid-pole of left kidney and right kidney small with altered CMD. So we have an ultrasound. What investigations would you suggest as a next line of investigation? What imaging?
MRI.
He has a creatinine of 2.4.
MRI.
You suggest MRI. How does the MRI help us?
On NCCT, whatever information we will get is not enough to distinguish it from an infection, number one. Number two, since we cannot do CECT because the patient is a CKD patient, we need to have at least an MRI to look at the images and then decide what the lesion is like, because MR, with its good contrast, can tell us a lot of things about the nature of the lesion, as well as about any other metastatic lesions if present, if it is at all an RCC.
So, any of this PET CT, does it help?
PET CT, I wouldn't do it now because infection and metastasis.
No, infection was 3 years back.
But then he might have a recurrent one also because CKD patients are prone to infections anyway.
So PET CT is not the primary mode of investigations. It's the secondary, and as mentioned in your lecture that since kidneys drain FDG, so PET CT is generally done for the metastatic workup only. So anyway, we had a CT scan. NCCT was done in this case, and these are the CT pictures. So it shows an anteriorly placed tumor, as 3 centimeter of the size. So what next?
On these images, since it is not a very avidly enhancing tumor, I don't have numbers, but it is not a very avidly enhancing tumor, so I cannot stamp this lesion as an RCC still now. So I would go in for a biopsy now, rather than doing any other investigation like MR now, because that is not going to help me either.
So an MRI was done, but the MRI images are not available with us, which suggested that it's probably an RCC.
Okay.
Then the next, how to go forward with this?
No, the question, as Gunjan said, is about the CT-guided biopsy. He comes here because it's an other kidney is small, it's not functioning. So, and in a history of pyonephrosis in the past, so everything can be distorted, and taking the kidney out may put him on the permanent dialysis. So before we move on, so we have to be sure about this. So this may be one of the cases where CT-guided biopsy could be done. It's my... Srinivas?
This is the ideal circumstance where we have to do an biopsy, because anyhow the surgical option of doing a partial or a radical nephrectomy is out of question because of his creatinine status. So we have to think of either doing an ablation or an active surveillance if the patient opts for it.
So I think there's not an iota of doubt here. This is the ideal situation. One kidney going half throttle, another kidney down with a tumor. We need to decide on the second kidney which is having the tumor, whether it's a good one or a bad guy. So we need to find that out. And the best thing is put in a needle, and it's only about less than 1% chance of a needle track. So this is the time we should get bold and do a needle.
Sir, suppose we decide, or the patient decides to go conservative and doesn't want an surgery or something. In that case, still do we suggest to have a biopsy?
Biopsy has
Because as in the first lecture we learned that in small renal masses, if we are not planning to intervene, then should the patient
The
undergo a
patient
biopsy?
is not willing for any treatment at all. Or is he not willing for surgery?
Willing for surgery.
If he's not willing for surgery but willing for systemic therapy, then obviously we need a biopsy.
So we should at least know the diagnosis to prognosticate the case.
Kalyan, anything to say or comment on this one? Or any other person? I can see Kalyan still.
No, there's an
No.
Contrast CT with the...
It's a non-contrast because his creatine was high.
I don't know, I'm not a radiologist.
Non-contrast.
Huh?
Plain city.
It's a plain CT. Okay. No, I've got nothing to add here actually. You've got to, the other kidney is small, and I think we have to get the help of a nephrologist here, because if there's a conversion to a radical nephrectomy on the left side, then the patient must be counseled about the need of post-operative renal support. But I think many of these patients can even do well with, survive for a few years without dialysis with a creatinine of 4 or 4.5, something like that. You maybe a renogram, that is the investigation which was missing in Pushkar's chart. Would a renogram help in managing this patient?
Small kidney was, I think, other thing, it was done by renogram, not put in there, documented.
So a true cut biopsy was done and it revealed an clear cell RCC. So now what are the treatment options? Should we go ahead with a watchful waiting in this case, a partial or a radical nephrectomy, or an ablation?
3 centimeter tumor, is that right? 3 centimeter?
3 centimeter tumor.
I think this is the time we should get a nephrologist into the team. That's why malignancy and cancers are always treated by an MDT, not by the whims and fancies of a single consultant. We need to know the renal function of the kidney which is small. We need to know the renal function of the kidney which is having the tumor. We need to find out which is doing okay or which is going bad. Next, we can devise on the treatment. Had there been the small kidney functioning at least some, I would be happy for any ablation, because the guy is, I think, 74-year-old. It's a 74-year-old gentleman. Ablation for the kidney having the tumor and having nephrologist help and counseling of the patient is very important. If we can do a nephron-sparing surgery, obviously the surgeon's ball game, then they can go ahead and do a nephron-sparing surgery. Still the better option than any ablative therapy.
I think this is the ideal case where only two options should be discussed. One is active surveillance, another is thermal ablation. Partial nephrectomy and radial nephrectomy is out of question because it will unnecessarily put patient into
dialysis, because the patient might live his normal life with this and we might just follow up with the increase in size and all once we know the biopsy and the nature. To our radiologist, so as per nephrometric score, how in what risk category should you keep this?
Sorry, I didn't get you.
The nephrometric score for this mass.
Okay. Again, this is a 3 centimeter, you said?
Yeah.
So that will be 1, and it is again 2, 3, and then the nearness will be again 3. It is an anterior mass, and it is midpolar, so it is 3. So 3, 3, 6, 2, 8, and 1, 9, again 9.
So it's a very difficult case for a partial.
So to summarize, Pushkar, as we discussed, 74-year, a difficult case for a nephron-sparing surgery. Creatinine, it's a CKD, and other kidneys will not support. So either watchful waiting or, if possible, RFA. But you need a biopsy.
Yeah.
For both RFA, you need a biopsy. For other, to establish this is a cancer and not a non-cancer situation, you need a biopsy.
Yeah. So an RFA was planned, but the challenge was, since it's an anterior tumor, placing the probes and preventing thermal injury to other nearby organs. So what are the options, sir, in case we do an RFA?
Basically, these are the one which are done either laparoscopically, because this is the gut is very nearby, or one can push the gut with a water jet, but not percutaneous, certainly, unlike the posterior ones.
So as we know, if you do an RFA or a cryo, if it's a posteriorly placed, you can do a percutaneous one, and if it's an anteriorly placed, it's preferable to do it under laparoscopy guided, where you dissect out the gut and the other neighboring structures to prevent their injury. So what was done?
I have one question for the surgeons. How about a robotic surgery? Because I saw a lot of robotics being done in small tumors in the Western world. So is there any chance of robotics giving improved surgical advantage vis-a-vis? This is my question to the surgeons.
No, true, but certainly it's an advantage over that one, but that's not a gospel truth that they will come out with that one. But in this sort of, unlike in other surgeries, pelvic surgeries, the robotic itself doesn't score that much in preserving the kidney. So that is not a great leap on that one.
It's definitely doable, but you have to judge because even if you do a partial with a robot and all, you have to clip the system and compromise with the vasculature for a particular time. So that takes toll of the nephrons which will be protecting him. So what was done was a hydrodissection. This separated the guts from the renal mass, and this is how you can see that the guts have been separated, and with the ablative needles in place, an RFA was done. And this is the ablation coverage, and post-operatively the creatinine shot up to 3.4, and now 2 weeks post-operatively it's somewhere around 3. So how do you follow up these patients?
Excuse me, was it done under anesthesia? Is it done under
The
general
RFA.
anesthesia?
RFA wasn't done under
This one?
anesthesia. Yeah.
With the water jet.
Yeah,
And the biopsy it showed RCC.
Yeah.
What was the prognostic criteria, IMDC or MSKCC? It's a poor risk, intermediate risk, or favorable. That's very important because 2020 is a new time, it's a new era for RCCs. We are getting into the era of adjuvant treatment. There are a number of trials, S-TRAC, for if it's a low, high-risk patient for metastatic RCC, even adjuvant therapy has come up. And it's approved, it's FDA approved. So we need to know the MSKCC or the IMDC. Now we are going with IMDC, no more with MSKCC. Whether it's a high risk, poor risk, or an intermediate risk. Rather in IMDC, it's good risk. Poor risk is the MSKCC term. It's very important to learn and know the risk criteria before we venture on a treatment because we can plan it accordingly.
Which means the anemia, the LDH,
Obviously, there are, the
erythrocytosis,
MSKCC has got 5 points, the
thrombocytosis.
IMDC has got 6 points.
So, how do these patients who undergo a RFA, how do you follow up them? With what imaging modality? And with particularly those who has a creatinine of
In
2.4.
this patient, we can't do a CT. But we will do a CT scan of chest, which will be a plain CT scan of chest. And we'll go in for an MRI without contrast. A PET CT is doubtful because scars will also have a high SUV max. So that's why PET CT might not be very helpful here. So we will first do an MR of the abdomen and a CT of the chest.
How good is the ultrasound follow-up with the Doppler and the elastographs?
So in these patients where we have had radio ablation, there'll already be a scar over there, which will mimic a mass because there's some engulfed fat and there'll be some abnormal echogenicity over there because the fat will be all burnt and things. So USG will not be very helpful in this case. We will not be able to say with much confidence whether it is there or
So
not.
gadolinium-free MRI will be the investigation of choice and follow-up. To our oncologist, how often do you recommend an imaging in the post-op period?
This depends. Again, I told you why it depends. We need to know whether it's a good, intermediate, or a high-risk case. In low risk or good risk IMDC, I will recommend it not earlier than 3 to 6 months in the first year. Thereafter, if the patient is okay. The first recurrence usually in good risk or poor risk patients, in good risk or low risk patients, is the first 2 years. The first 2 years, the first year will be a 3-monthly follow-up. Second year, 6 monthly. The patient is okay. We will carry out with, say, 8 months to 12 months follow-up. But the first and most important thing, we need to know the risk of
Risk
recurrence.
stratify the patients. So our third case is a 59-year-old male presented with a left abdominal pain and back pain. CT scan revealed a 3.6 centimeter left renal tumor with another 3 centimeter para-aortic lymph node. So what imaging, what extra imaging should we do in this case, or do we need any other further imaging to prognosticate this case or to make us wiser?
This is on a contrast CT.
This is a contrast CT.
It is an enhancing tumor. I don't think we need any other further imaging to say that it is a...
Regarding the para-aortic node,
The para-aortic node, if it is enhancing to the eye, the images are not very clear. If it looks similar to the mother lesion in the kidney, then it is very unlikely to be of some other pathology. It should be similar to the renal lesion. So maybe we can do a biopsy maximum of the para-aortic node to establish that it is a metastatic lesion and then go ahead.
preoperative biopsy.
I will first recommend an MR brain and a CT thorax in this case. That should be done. That's the first thing should be done is an MR brain and a CT thorax. Get rid of these 2 areas. There is no mets elsewhere. Then think of the knife and put in a needle. If there is a metastasis to the lung, So it's very easy to get a biopsy from the lung as well if it's an accessible one. So the first, metastatic screen. Second, prognostication. Third, thinking about the plan. Fourth, it should be an MDT, nothing less than that. There are no ifs and buts in all these treatment protocols.
True. Can I ask Dr. Nadeem, how good is it, a biopsy from the para-aortic node and the lesion itself, mother lesion? Which one is the more, or is it the same value?
Yeah, I would prefer to do the biopsy from the primary lesion, not to the node, not at all. Actually, the primary lesion will give us more information than the node per se. And that would be the primary area to hit first, and then decide exactly what to do next.
So in this case, preferably we should have a biopsy of the node before planning for the workup.
Not for the diagnosis part, but we are talking about, I mean, the first part I got the answer. Second was the node is is a metastatic node or not. So you can take a CT-guided biopsy from the node.
Yeah, of course.
And that will give the...
That will definitely give all the information, which is very important. Right?
One of my cases, all these are recurrent cases, similar note came, and there was a time lag. By the time patient came back, there was a liquefaction. And so it was a tuberculous node. So it can happen like that.
So in this case, a PET CT was done, and it showed there was enhancement in the uptake, FDG uptake in the nodes. Pre-operative biopsy was not done in this case. So it was a metabolically active left renal mass, metabolically active para-aortic lymph node metastatic, metabolically active right cervical, supraclavicular, paraesophageal lymph node likely metastatic. So what are the treatment options? Neoadjuvant targeted therapy, metastatectomy.
So this is a situation that it's a tumor with widespread metastasis. So it's a systemic disease to begin with. Now there is a trial called an excellent trial is called Carmina trial. The Carmina trial has shown very specifically, it's crystal, that except in very, very few chosen oligometastatic disease, there is no role of cytoreductive nephrectomy in metastatic cases of renal cell carcinoma. So what's oligometastatic? Oligometastatic is usually metastasis which are resectable, accessible, and we think that too few metastases, reducing the tumor burden, can help the oncologist to deal better. So in most of the cases in the Carmina trial, even with taking into account the oligometastatic cases, sunitinib scored better. So going by this trial and data, there is very little role, rather very, very little role of surgery or cytoreductive nephrectomy or metastatectomy, even oligometastatectomy, so far as systemic disease is concerned. My money is with a first generation TKI. My money is with a sunitinib or a pazopanib.
But in difficult cases now, the EAU guideline says you can do a neoadjuvant TKI or checkpoint inhibitors, and which makes the apparently inoperable tumor operable.
Six trials going on with neoadjuvant. The data is not yet enriched. We haven't yet reached the median survival advantages, even with these trials of neoadjuvant. It's very, very difficult now to comment on neoadjuvant therapy. It's a virgin area we are treading on. So it will take time. It will take at least 2 years. 2022, we will be able to present a classic neoadjuvant, just like the breast, just like the cervix. We will be able to present a classic neoadjuvant regimen protocol. But as of now, the choice is very little. It's oligometastatectomy versus sunitinib.
But cytoreductive nephrectomy plus the adjuvant therapy is said to have increased the OS from 9 to 20 months.
The Carmina trial, sir, has already shown very specifically there isn't any advantage. Again, going by historical evidences, there had been anecdotal incidences of tumors vanishing. Sir, you have excellent practical experience. You have seen, I had been your student. Even now I've spent 25 years in practice. So I am yet to see post-nephrectomy metastasis vanishing. I'm yet to see. That's my personal. Anecdotes never make guidelines. There had been historical evidences, but that's why what the guidelines say, the Carmina trials say, in very, very few chosen cases, one should choose cytoreductive nephrectomy and metastatectomy. As of now, my money again is with a TKI.
And Doctor, what is your take on lymph node clearance in a case of, had it been there was no cervical mets and all, it's only a hilar lymph nodes and para-aortic lymph node was there?
No, I think this has been clearly in all the guidelines that there is no role of prophylactic lymph node dissection. But if there are nodes palpable or in the city, then there is obviously chance of a recommendation of lymph node clearance. Like this one will be done, if you at all, oligometastatic one.
So can we have an opinion of the House?
Any inputs? Kalyan? Nodes?
I agree with you. I agree with what you say that if at the time of surgery you find that there are enlarged palpable nodes, you remove them and do ipsilateral lymphadenectomy, up to the level of the bifurcation on either side and the cross, if the nodes are enlarged.
But sir, if there is metastasis elsewhere, will you still recommend?
No, not in that situation. That was he said that if there were no other metastasis.
Absolutely.
It is for sampling only.
The difference is the breast model doesn't fit into the kidney model. So the surgeons must be aware, because all as general surgeons after all, the breast model doesn't it's not one size fits all. Even in the TKIs, it's not one size fits all. We are many t-shirts. So we'll have to choose according to the body.
And in this case, it's a small mass with a lymph node. So, will there be a role of a partial nephrectomy with the lymphadenectomy?
I think so. Obviously, the surgeons will answer.
No, I think that's a very viable proposition because nowadays, even if it's a renal tumor metastatic disease, you do not go for radical nephrectomy, you go for a nephron swelling because you have to give the quality life. In any way, he's not going to survive longer if you have to do it. But as I said, the TKI is the answer probably.
So we move on to our next case. It's a 65-year-old male admitted with dizziness, vertigo, decreased vision for few days. USG abdomen reveals a poorly circumscribed mixed hyperechoic SOL arising from the left kidney. So this is an ultrasound finding which shows us 7 or 8 centimeter into 6 into 6.5 centimeter tumor in the mid pole. And the echo revealed a large echogenic mass traversing all the way from IVC into the right atrium and entering into the right ventricle in diastole, suggesting of large thrombus extending from the IVC. So what other imaging will help us?
For this patient, I would go for a PET CT because you said that the patient was having a decreased vision and he was having some visual symptoms also.
PET CTs, PET scans are not the investigation of choice of excluding brain mets.
No, they already have, they say they've seen an IVC thrombus also. Yeah. So if we see on PET CT that the thrombus, we already know there's a thrombus. Now, if the thrombus, whether it is PET bright or not, and whether there are other mets elsewhere also, we will be able to, we will be able to
Perhaps
see the disease load.
My choice will be an MR brain. To begin with, I will go for an MR brain.
So
first fix the brain, next think of anything else.
MRI of the abdomen is not going to give you any further.
No.
That's enough.
I'll do an MR
We know
brain.
enough. It's the other organs, the brain.
I'll do an MR brain.
No, will that MRI of the abdomen, will that make us anyway wiser by saying that whether the thrombus has invaded into the involved the IVC or not, IVC wall or not?
We need to differentiate whether it is a bland thrombus or whether it is a thrombus which is a tumor thrombus, or whether the wall is invaded or not. So if we can give contrast, it is going to help us MR abdomen. But if in case we are unable to give contrast, which was not stated like that, like we can give contrast.
He has a normal creatinine.
So if we can give contrast, then yes, MR will help us in differentiating a tumor thrombus from a bland thrombus and the invasion.
And because that will alter the management as well.
Not only the bland you are talking to,
And
what
also
we are
the extent.
interested, whether it's a T3C or T4,
So the
whether
echo-
there's an infiltration of the vena cava or not.
Yes.
That's the thing.
I'll be more interested in excluding as M1. So the first thing to exclude is M1.
One track mind.
Obviously, sir. Sorry.
This patient was having the syncopal attack because of the right A lesion.
So this is the echo picture. You can see that the thrombus popping inside the RA with each diastole.
Okay, we have seen that one. Show off.
How
Go on,
about the
next one.
CT angio here? CT angio? Because this patient can have a pulmonary embolism as well.
Yes.
So the CTPA comes into the picture, the CT
Yes.
angio, because these patients are more prone to PE and DVT. So we need to exclude that as
True,
well.
true. It'll be of help to see the extent of the thrombus and whether there have been emboluses in the pulmonary
In the
system also. Emboli.
So we don't have a very good picture of this. It is showing that the tumor is extending inside into the suprahepatic part of the IVC and entering into the right atrium. And this is the CT scan features. So we had already discussed this for the assessment of the thrombus, what are the options we have. Whether a Doppler helps.
Not very much. It will not tell us. Yes, if it is a very, very hypervascular tumor, it might show some vascularity. But if there is no vascularity or hypovascularity, we cannot exclude a tumor thrombus.
So essentially an MR should be done.
Yes, with contrast.
So surgical approach, sir, what will be the preferable for such a case? Whether it's a subcostal with extensions?
Yeah, we asked the surgeon. Srinivas.
This case was done with help of cardiothoracic surgeon Dr. Mandana, and we did an thoracoabdominal incision extending subcostal into the from entering midline from the G sternum. This case was done under total circulatory arrest because we have to remove the entire tumor in totality.
So this is the perioperative pictures. Here you see the atrium has been opened and patient was on circulatory arrest on a bypass. And this is the thrombus. This is the specimen.
So we have seen lots of cases with thrombus being taken out and circulatory arrest done. The thing to look after in the post-op period, because the surgeons always operate and they vanish, and the oncologist has got the duty to do the post-operative rounds as well. We see jaundice. So that's something which I was scared of. In the first case I did, I was stunned to find jaundice the next day, and the cardiac anesthetist came and patted on my back. This is very common. So even for the residents and the registrars, if there is a circulatory arrest, the liver goes down for say about 1-2 hours, and there is very likelihood of having a post-operative jaundice, which might be about 5-6 bilirubin, not to get scared of.
No, this patient came to me 2 days back. He's now 6 months into post-operative
No,
period.
that's in the first immediate 2-3 post-op days we find
The
jaundice.
good thing about this tumor, the entire tumor thrombus was free. What I did, I dissected the kidney, I put an incision just to disconnect the tumor thrombus, and they opened the heart, right atrium, and took out the entire thing in one piece from the atrium itself. Everything came out smoothly. There was
It's like taking a snake out
Yeah,
of the
yeah.
hole.
The one thing I must tell you, the TEE, the transesophageal echocardiography, works wonder here. I had one case similar on the right side, and while doing it, there was total anuria. I got panicked that I have done something to the left side. The TEE, the anesthetist they put in, and then told me exactly the RI index on that one and assured me that this is going to function, there is no injury, and within 10 minutes, the kidney started to function. So that's so wonderful equipment to have it in hand. We have got any more?
Sir, I think
Now we have got a question. Thank you. The wonderful case. There is a question from Nagpur. Dr. Kulkarni asks to the panel, Pushkar, to you first. It's a bilateral RCC with IVC thrombus from the larger tumor and hematuria persistent. Which side to operate first? Colin, get ready to answer. Anyone? Bilateral RCC with the IVC thrombus from the larger tumor, larger side, and hematuria persistent. To which side to operate?
Sir, it depends on the size and how the other side is, because here you have a challenge of treating him symptomatically to stop the hematuria, as well as to give him maximum nephron sparing, scope of maximum nephron sparing. If it's large tumor on both sides and both sides are non-viable for a nephron sparing surgery, then it might be, patient might become anephric. You might have to do both together. But if it's a nephron sparing is possible on the other side, then maybe you have to take a chance and go in the single go. You do the IVC thrombectomy and do the nephrectomy, as well as in the same sitting you have to do the nephron sparing.
One thing I would like to ask you, this is IVC thrombus will cause the bleeding, or there is a scope of embolization to stop the bleeding? The persistent hematuria is the word which you are giving an importance. So it could be if you can embolize that kidney and stop the bleeding, and then we deal with that IVC thrombus, because IVC thrombus per se will not be giving hematuria.
No, it doesn't give hematuria.
So that's a tumor eroding the calyx.
Into the calyceal system.
So what's the answer? Any input from the floor? Ayush? PK?
It's bleeding. Then we can do the nephrectomy of that side.
That's it. Any other inputs? So we go for the next question. Next question is a very interesting question. Very interesting. It's from Mahesh Desai, Nadiad. Congratulations for organizing such good symposium on small renal mass. Congratulations. Okay, so next. Imphal, Dr. Somarendra. 47-year female with multifocal AML with recurrent episodes of gross hematuria. Two of the lesions, 2.4 centimeter each, suspicious of RCC, subtle enhanced scattered minimal fat intensity, line of management.
Oh dear.
Multifocal AML with recurrent episode of gross hematuria. Two lesions, 2.4 centimeter, are suspicious of RCC because of the subtle enhanced scattered minimal. How importance would you give it?
Some RCCs contain fat also. So since there is a hematuria and the lesions are suspicious for RCC, I think we would go ahead with a biopsy to establish whether it is an RCC and then go ahead with some surgery.
I think we need to address another thing, whether this bleeding is due to AML per se. Need to find out whether the platelets are okay, the coag profile is okay or not, whether the AML is being treated, whether it's in control, it's in CR. So those are the things we should take into account.
AML, I think they meant angiomyolipoma.
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 Yeah.
So in that case, obviously, it's a difficult choice.
It is a size criteria. The size is quite small. And to attribute bleeding to those sizes, it's difficult unless until it is seen.
So it's a bilateral they have mentioned, bilateral AML.
there any use of using chemotherapy, oral
mTOR inhibitors.
everolimus
Yeah,
and
exactly,
something
sir.
for
Exactly. mTOR
angiomyolipoma?
inhibitors is the drug which we use at times because it really reduces bleeding and hematuria that we have used. But there is no specific guidelines that it's a drug of choice for hematuria. No, there's no specific guidelines. But yeah, for that, everolimus mTOR inhibitors are there.
But surely in this case, the basics are we have to lateralize which the bleeding is coming from which kidney, and a cystoscope to find out external bladder tumors. So these are the basics. And then we are in trouble. We put ourselves into the soup or if there is no lateralization, if it's coming from the both sides. So I don't know if the selective embolization works or not there. I've got no idea.
Maybe, sir, we need to do selective biopsies of the suspicious lesions. And if they come out to be a malignancy, then RFA may be our choice, RFA or cryo.
Okay. We should do CT angio first.
Sure.
We have to.
In fact, this is where not only biopsy, immunohistochemistry would come into play.
Yeah, they have
It is
done
very
the biopsy.
essential.
They have not done it. They will.
To find out a diagnosis, because AML and sarcomatoid RCC will really fight it out.
Right. This is now one from Jodhpur, Dr. Gautam Chaudhary. Question to the radiologist. Left anterior tumor in CKD, how will you plan biopsy that patient?
If I have a fat plane between the spleen and the kidney, then it is easy. Otherwise, I will go transplanic, although there is, it has its own risks, but it is done, it is documented.
So it's if they are planning percutaneous biopsy, then it's more likely harm the kidney because the needle path is most likely injure vessels. It is one of the favorable locations for the partial nephrectomy with a robot, and further partial nephrectomy meant to treat tumor in CKD. The same thing, I disagree RF and cryo because it is in a difficult position. So that's what we discussed, the last one.
That very patient was having too many comorbidities with creatine, high creatine, somewhere around 3. The active surveillance is a better option rather than doing something else.
His point is that in single kidney, partial nephrectomy is meant to treat tumor in CKD. And RF is not the one which is not a solution. Well, that's a thought. It's one from Imphal, RIMS, Dr. Adhikari and Dr. Pavan Kumar. In case of type 3 renal cyst, anterior, not proven RCC, 3 centimeter in size, what about anterior wedge dissection? Or watchful waiting? Patient's choice is watchful waiting.
It's ideal for watchful waiting because the oncological potentials are less, so we can watch and we can always intervene if we think the size age is also a factor, and we can always intervene if it grows rapidly.
Thank you. The one from Noida is the role of targeted therapy post-radical nephrectomy in T4 disease.
Yeah, the targeted therapies have come in a big way. A large number of trials are there. The ESTRAC trial has clearly shown the advantage of sunitinib as an adjuvant therapy in poor risk patients, even in intermediate risk patients. So sunitinib is the drug of choice as an adjuvant therapy, as it already approved by the FDA in 2018.
Is liverlumab available here?
I think the targeted therapy means sunitinib. Basically, sunitinib is also a targeted target.
In your practice?
Nivolumab is pretty much available. But we usually use it only for advanced metastatic carcinomas.
Okay. Well, thank you very much. I think that's all the cases we had. Now, we had cases. We had to stop here because it's already quite late. I thank all the panelists for their participation, wholehearted participation, and to all of you and to all of you in the other centers for holding for so late. And I thank you, Alchem Eurocare, once more for giving us the chance. Thank you very much.
Thank you very much, Dr. Shivaji Basu, nicely moderating and chairing the dinner session. I profusely thank all the speaker and panelists for the nice deliberation. I thank the hotel partners here across and all the audience and all the speakers across the country. I take this opportunity to thank our webcast partners, Banyan Tree, for conducting this webcast very nicely. At Alkem Eurocare, I wish to take this opportunity to reconfirm our commitment, sir. Number one, we continue our efforts to bring innovative product range. It can be a product or it can be a formulation. The first initiative that we have taken in this range was bringing the first single dose tablet of silodocin and dutasteride in the form of Maximoid Plus. That was an innovation from our side and the world is following. Second, our commitment is to add value-added scientific services. The first initiative was to build this Saturday School of Urology, a real scientific program. Thank you, Dr. Basu, and all eminent urologists to make this happen. And third is to bring a lot of services to the patient. We understand that patients are important, and a lot of awareness and support needs to be patient. So with these three commitments, we thank all of you once again. I request all of you to join for networking session followed by dinner. I'll request the panelists to just wait for 1 minute.